Okay, good morning. Just a couple lectures left before lunch in the lab. So there will be a couple of things that will be redundant in this in my talk regarding the foot, but not too much. I'm going to, again, like all the other lectures, talk about some of the ultrasound techniques, considerations unique to imaging the foot and the toe, some pertinent anatomy, and spend some time with specific examples. Now, through this course, hopefully you've been able to develop in your mind kind of pros and cons of ultrasound in musculoskeletal evaluation. I'm not going to go through all of these, but this is a list that actually Tudor Hughes from UCSD put out, and under his pros he has FAST. And now, for many of us, as we're learning, FAST is not necessarily about an advantage to musculoskeletal ultrasound, but if you've got a great technologist, someone that knows what they're doing, and if you're pretty facile and hands-on, it certainly could be the case. You've seen some of the cases where we have poor soft tissue contrast resolution. Sometimes that can be aided with MRI when we're evaluating tumors, but again, soft tissue tumors are often difficult to subdivide on MRI as well. And of course, it's operator-dependent, habitus-dependent, like many things in radiology. But the benefit is you can go side to side, look both sides, normal to abnormal. It's interactive. The patient can tell you where they hurt, when they hurt it, and whether it's better or worse than when the referral was made. Sometimes if you're imaging these people a week or two after the request for ultrasound, their symptoms may have gone away, or they may not, or they may have changed in character. So again, high frequency linear array transducer, very beneficial in the extremities, hands, fingers, toes. Now, I mentioned here a water bath technique. It can help when you've got difficult surfaces that are hard to couple. And I'm actually surprised that this technique has not come up thus far in this lecture. It actually makes me a little bit nervous that maybe some of you guys out there that do more of this than, than some of us know something about this technique that I don't. But I find it very, very helpful in the toes and the fingers. Now, this is a throwback to original ultrasound imaging when it used to be done in a literal water bath to couple the transducer with the patient. And we've gotten away from that now that we have nice gels with less impedance than actually water and can give you pretty good images. But when you're dealing with a foot or a finger or a toe and you're just having a hard time really getting a good, really getting the transducer to give you a good image, the water bath can be very helpful. The transducer is sealed. You know that because you can put it in various parts of the body and sterilize it afterwards without risking any contamination within the transducer itself. So they generally do just fine in this water bath. And we use this, I found this pretty beneficial, especially when you're looking for foreign bodies in the hands or the fingers, especially in kids when it's been in there for a while. It's extremely painful, and they don't want any pressure from a transducer. You put them in this water bath, you don't have to touch their foot. You can leave the transducer 1 or 2 inches off the skin surface. And you can look, and it's just like they just put it underwater, and that's all that they know. And of course, you do this daily when you're looking at OB ultrasound. This is like the anatomic water bath with the amniotic fluid providing that acoustic window. So we found this pretty helpful, and we use this a lot. You'll see some of the images that I'll share with you today are from using this water bath technique. So a few common indications of that we'll go through. We've already talked a little bit about plantar fasciitis, and just to reiterate, I'll show you a couple cases as well. Like any muscular or tendinous structure, the plantar fascia should be uniformly fibrillar, 3 to 4 millimeters thick, no greater than 5. And again, because of the anisotropy, it may have a hypoechoic appearance at the calcaneal attachment. If it's thickened to 5 to 6 millimeters, diffusely hypoechoic, excuse me, or increased Doppler flow. Those are findings that would suggest plantar fasciitis. This is an example from an AJR article, just of a anatomic demonstration of the plantar fascia. The normal plantar fascia had its calcaneal attachment. And again, there's 3 described bands of the plantar fascia. Clinically, 2 are relevant. The central, which is more commonly called the medial band clinically, is the one that's typically involved. From that same article, a demonstration of the plantar fascia on ultrasound. And this is an example of the normal appearing plantar fascia that you can follow from the calcaneus through the plantar aspect of the foot. You can turn transversely on the plantar fascia and follow it as it attaches to the calcaneus, and again you should see a fairly homogeneous thickness as well as homogeneous echotexture to the plantar fascia, as demonstrated here between the two arrows and highlighted. So this is a case taken from the literature about plantar fasciitis, and you can see the contralateral normal plantar fascia on this side and a thickened and hypoechoic plantar fascia on the affected side. And you can see that this might be a little bit, if you're just only imaging the affected side, you can use your measurements as a rather hard and fast criteria, but imaging the contralateral side can help you get a better internal reference of what the normal plantar fascia might look like. And this is helpful when only one side is affected, not helpful if they have bilateral plantar fasciitis. Doppler is helpful in evaluating tendinopathy on any site with increased neovascularity, but certainly so in the plantar fascia. And this is an example of using Doppler to demonstrate increased vascularity at the calcaneal attachment of the plantar fascia. Plantar fibroma also well demonstrated by ultrasound because of its fairly superficial position. The plantar fibromas usually are well seen. They're relatively hypoechoic to the adjacent structures within the plantar aspect of the foot. Remember, you've got a ton of subcutaneous and deep fat, and then the more deep to the plantar fascia, you've got the deep forefoot muscles. And this is an example from radiographics showing this fusiform hypoechoic plantar fibroma. Now, commonly we're imaging these on MRI, but it is certainly possible to diagnose them on ultrasound. So I'm going to switch to some of the midfoot ligaments. And with ultrasound, you can see a lot of anatomy in the foot. Let's start by looking at the plantar calcaneonavicular ligament, or more commonly called spring ligament. Now, this is a diagram taken of the foot with the talus removed and obviously the tibia and fibula. So you're looking down on the calcaneus, down basically on the inferior half of the subtalar joint. One way maybe to visualize this is disarticulate the subtalar joint, perhaps like this, and then pretend you're looking down upon the subtalar joint like that. And this is what we're getting this diagram from. And you would be looking at the spring ligament complex. And in this case, you can actually see the superior medial oblique bundle of the spring ligament complex extending from the sustentaculum to the navicular, as demonstrated by the arrowheads. More superficial to that, demonstrated by the arrows, is the posterior tibial tendon. And I'm assuming that I have not seen the tibial slip, but I'm sure that you could see that as well. Talonavicular ligament, again, the image demonstrated the transducer position of the dorsal aspect of this ligament from the talar head to the navicular, again, demonstrated well with ultrasound. And the lateral limb of the bifurcate ligament from the calcaneus to the cuboid, again with the transducer positioned longitudinally over the lateral aspect of the foot, is well demonstrated. Moving to the Lisfranc ligament, we're used to looking for these on MRI, but it is possible to see them on ultrasound as well. This is a good example, again utilizing that water bath technique. You can see that the transducer is not at all adjacent to the skin surface, but this acoustic window is afforded by the water which the foot is sitting in, and you can see the Lisfranc ligament in its expected location. Now, in the plantar aspect of the foot is a plantar Lisfranc ligament separate from the Lisfranc ligament proper. This extends from the medial cuneiform to the base of the third metatarsal, as opposed to the base of the second metatarsal from the Lisfranc ligament. But this is actually able to be seen on ultrasound as well. This is an example, again, from the literature on the plantar aspect of the foot with the transducer oriented in this position. And you can see that this is the Peroneus Longus tendon, and this is the ligament on the plantar aspect of the foot, which this article has labeled the Lisfranc ligament, demonstrating this as the second metatarsal. I think if a correlation with an MRI and retrospective review would actually show that to be the third metatarsal, and this would be the plantar Lisfranc ligament, just based on the orientation of the true Lisfranc ligament being more dorsally oriented. Some of the tendons of the midfoot now, well, we've heard about these through their extent from the ankle distally, so this may be a little bit redundant, but the Peroneus Longus tendon, as it extends to the level of the cuboid, you can see, and as it courses through the groove along the plantar aspect of the foot, the Peroneus Longus can be demonstrated through its course attaching to the base of the first metatarsal. And here you can see the nice fibular pattern, homogeneous thickness fibular pattern of the Peroneus Longus with the more deeper cortices of the cuneiforms. This is a corresponding MRI image, and if we flip it to put it in the same orientation, you can see that they correlate fairly well. Flexor and extensor tendons of the foot are easily seen on ultrasound. The problem is the anatomy. There's, you've got flexor tendons, deep superficial lumbricals, interosseous muscles as well, and so here you can see the more echogenic flexor tendons with the more adjacent hypoechoic lumbrical muscles. Now they're able to be demonstrated on ultrasound. Whether it might change management if the lumbrical muscle is injured or not, I'm uncertain. But we can see it. The extensor hallicus, the midfoot, you can see again that kind of normal tendinous pattern that you would expect. Here's our level of our midfoot, and again you can follow it like Dr. Wang said from the ankle all the way to the toe. At the MTP joint, again you can see that nice tendinous pattern, level of metatarsal head, MTP joint, as it goes through the extensor apparatus, which we'll talk about in a minute. And at the termination, attachment on the distal phalanx, interphalangeal joint. Again, you can follow that tendon all the way out. So the extensor hood, it's the nice thing about giving this talk after the finger talk is that there's a lot of things that are very similar in the foot, specifically in the toe, that compared to the finger. And so the extensor mechanism is very similar, as the plantar plate that we'll talk about in a minute is very similar to the volar plate in the finger. And so this is the extensor hood, which is basically, as described, a hood-like connection of the extensor mechanism involving both the extensor tendon, some of the connective tissue as well, that completes a hood-like formation over the extensor surface of the toe as well. So these are off midline sagittal images demonstrating not the tendon itself, but the extensor hood at the level of the MTP joint. And this is the transverse image showing you the extent of that extensor hood with the paired dorsal vessels on either side. And again, the extensor hood on the opposite side. This is a corresponding MRI image showing what it would look like. This is a patient, I don't remember her age, she was a senior airman, fairly active, who had a bunion surgery that was repaired, and this is her post-operatively. Now, her foot doesn't look like this anymore. She has since had all of the hardware removed because her surgery was complicated by a traumatic, well, I should say, iatrogenic tendonopathy with a resultant extensor hallicus longus tendon rupture from one of the metatarsal screws was somewhat proud, caused an impingement on the tendon and a resultant rupture. So she went in, she had screw removal and a primary repair of the tendon itself, but afterwards she was referred to us because of a persistent palpable abnormality on the dorsum of the foot, just proximal to the first MTP joint. And so we interrogated that area just to see what was going on. So this is a kind of dynamic cine clip, and I've got some still images of this that I'll show you in just a second. This coursing hypoechoic structure is vascular, is a vein on the dorsum of the foot. We talked about yesterday in the anatomy lab. You'll see those on the hand, you'll see them on the wrist, you'll see them on the foot. They're pretty easy to make sure the vessels will easily efface. But what we're looking at here is this is the extensor hallicus longus tendon, and as we come through it, you'll see that it starts to get thickened, it becomes irregular, it's inhomogeneous echotexture, and there's a fair amount of surrounding tenosynovial fluid. And it actually looks like there's some echogenic material connecting the tendon sheath to the tendon itself, and I'm not sure if that's a post-surgical material. or if it's some other soft tissue material causing a stenosing tenosynovitis. She has limited range of motion with this associated palpable defect in a mild amount of tenosynovitis. So these are some still images taken from this patient. Here's the extensor tendon proximally. As we follow it out, you start to see the extension of the tendon sheath, tenosynovial fluid, thickening and irregularity of the extensor tendon itself. Similar pattern as we come a little more distally. And we actually offered a tendon sheath injection to her, however she declined. She had already had enough iatrogenesis imperfecta at that point and decided she would just try more conservative measures. So this is a different patient demonstrating extensor tenosynovitis with Doppler flow with hyperemia. Let's turn to the plantar plate, plantar aspect of the foot. Lance mentioned PRP becoming popularized in the sports media and ESPN. Well, turf toe is one of those other terms that you hear about. And I've had residents actually ask me, is that really such a thing? Is it really turf toe? And the answer is yes, there is. Again, it's a clinical term like athletic pubalgia to describe a spectrum of pathologies involving the plantar aspect of the toe, much of which is centered around the plantar plate, which is this fibrocartilaginous thickening of the plantar aspect of the joint capsule. It attaches to the metatarsal neck, the proximal phalanx, the sesmoids, and the collateral ligaments, and is one of those structures injured in that turf toe complex. So please forgive my rough diagram, maybe with a acromegalic patient or something like that, but this is just a crude diagram demonstrating the major anatomy in the region. The Flexor Hallicus longus tendon, as it's coursing on the plantar aspect of the foot at the level of the MTP joint. Deep to that, you'll have the intersesamoid ligament. Now I'm drawing this. It's taken precisely between both sesamoids, so I didn't have to put either of those on. But this is a ligament that connects both the sesamoids. Deep to that is this thickened plantar aspect of the capsule, the plantar plate, and it has a fairly proximal attachment on the metatarsal near the head-neck junction, and out on the plantar aspect of the proximal phalanx. In the transverse diagram, now taken through the level of the sesamoids, you can see the metatarsal head, the central crista with the articular surfaces for each sesamoid on either side, the lateral or fibular hallux sesamoid, and the tibial, connected between the two with the intersesamoid ligament. Just superficial to that is the Flexor Hallicus longus tendon, which is diagrammed as this round structure. Deep to that is the plantar plate. So a little bit, it's semi-complex anatomy, but it's actually very interesting. You've got the two paired sesamoids. You've got the plantar pad, some fibrous connective tissue on the superficial aspect. Just deep to that, the FHL. Deep to that, the intersesamoid ligament, and then the plantar plate. You've got the rest of the capsule connecting to the collateral ligaments. And it's anything that's injured in this region falls under that turf toe clinical scenario. So whether it's an injury to this intersesamoid ligament or the plantar plate, or perhaps one of the collateral ligaments in association with any of those. So on ultrasound, this is an example of the Flexor Hallicus longus, metatarsal head, proximal phalanx, and this is the plantar plate, a slightly more echogenic structure deep to the FHL. On transverse view, imaging from the plantar aspect, so this is kind of the ball of the great toe. Here's our sesamoids, our central crista, with the sesamoids positioned about the crista, our intersesamoid ligament between the two, and more superficially, our Flexor Hallicus longus. I think the plantar plate is a little bit difficult to evaluate in this projection, but others with more experience may think otherwise, and I would and may be able to give some tips as far as how to see it transversely at the level of the sesamoids. Now, more superficial to that entire apparatus that I just talked about is the submetatarsal bursa, which can certainly become inflamed, and this is an example of the submetatarsal bursitis with bursal fluid and hyperemia. which could be amenable if requested for aspiration into therapeutic treatment. You can see the collateral ligaments well with ultrasound, probably better than you could with MRI. And this is an example of the medial collateral ligament at the level of first MTP joint. Joint spaces and recesses. So we talked a little bit about the plantar plate. Well, on the dorsal aspect, you've got the dorsal capsule. Not as thick as the plantar portion, but again, it has a fairly proximal attachment and leaves a small dorsal recess. Now, the literature is a little mixed on what a normal size of a dorsal recess is. Some people say 1 millimeter, some 1.5, but I like to think of it as a hip, is that you've got a lot of others that you can compare it to see if one is focally asymmetric and full. And so I don't stick to a hard, fast number. Within that dorsal recess or anywhere else in the joint spaces, you can see synovial hypertrophy, but often if that dorsal recess is displaced, full or distended, that might be your first sign of the synovial hypertrophy. Synovial hypertrophy is either non-displaceable or mildly displaceable. It's intra-articular and non-compressible as well. You'll see increased blood flow. Just make sure you're not getting faked out by anisotropy from adjacent muscles. It is possible, especially with like the Flexor Hallicus brevis, if you're around the level of the sesamoids or the adductor hallicus, that if you're getting anisotropy, it can look like a fluid collection. So really make sure you heel the toe and change your transducer position to make sure what you're seeing is fluid. This is an example of a lady that, again, we were sent to treat because of, they thought she had a bursitis. Turned out she actually had some synovitis and arthrosis in her first MTP joint. You can see the proximal phalanx. Here's the first metatarsal. We're just off of midline, so we're not at the level of the extensor tendon. But you can see the distended dorsal capsule. You can see how far back that capsule comes on the metatarsal. And also lots of areas of nodular synovial thickening. This is just an example of a picture at the same image with Doppler. This is not my case, however, the previous one was. Ganglion and synovial cysts, again, like in the wrist and the hand, is a common indication for foot ultrasound. And this is an example of a typical ganglion cyst located at the level of the midfoot. Again, this image just to remind us to always use Doppler to evaluate what we think may or may not be a cystic mass anywhere under ultrasound. And often you can see a communication of the cyst with one of the joint spaces. So here's articulation of our third and fourth metatarsal. And you can see a little neck coming out, and as you follow it around, you could actually see it coming along the inferior portion of this, wrapping around and eventually spilling into this ganglion. I think you can see that here on this cine clip. Now, I'm smart enough to get these clips into the presentation, but I'm not smart enough to know how to play them backwards. So you can kind of see how it comes over and dives down right there. If I were to reverse it, you'd see it come out and go the opposite way. But it's kind of a nicely depicted example of a communicating cyst. This is another patient who was referred to us because they had a palpable abnormality at the first MTP joint following bunionectomy. I hope you're not sensing a theme here. This is done again with water bath technique. Notice the transducer is a good few millimeters off the surface of this very tender toe, and you can see that there's an area of heterogeneous soft tissue. They were wondering, is there a bursitis there, or is this postoperative scar tissue? And this demonstrates a fairly solid postoperative scar tissue without evidence of bursitis. We obviously did not inject this patient at that point. Morton's neuroma can be imaged with MRI, but many people image it with ultrasound. Both transverse and longitudinal evaluation is utilized. You can the benefit to ultrasound is it's dynamic. You can do the ultrasound equivalent of the clinical molar click, where you squeeze the metatarsals together, elicit the pain, and see movement of the neuroma between the metatarsals. You can use Doppler to interrogate it, and you can help differentiate it from an intermetatarsal bursa. The difference between a neuroma and a bursa, both are going to be hypoechoic. Bursa should be anechoic, but sometimes it's a little difficult to differentiate the two. Neuroma usually will have increased Doppler flow. You may need to put power Doppler on there just to confirm that. The neuroma should be entirely non-compressible. The bursa should be at least partially compressible, but in most of the examples that I've seen, that it's not entirely compressible. but again, should otherwise follow a bursa pattern with hypoanechoic and no flow. So if you remember, if you've seen these on MRI, you're looking at your short axis T1 sequence, you see effacement of that normal intermetatarsal fat and a fairly characteristic teardrop-like shape. This is the ultrasound equivalent, showing this effacement of the fat with a somewhat intermediate echo texture structure, but certainly not homogeneously hypo or anechoic. This is a useless slide from a recent or semi-recent AJR article showing a Morton's neuroma, but with no, again, no adjacent structures. But I thought that it was helpful that it does show Doppler flow and it shows relatively hypoechoic appearance. But otherwise, I could have told you this was a invasive ductal carcinoma. Now, foreign body evaluation, we've talked about this a little bit already in a few lectures, and I think that this is where ultrasound is really, really good. During fellowship and residency, we had the opportunity to diagnose lots of wood splinters with ultrasound, sea urchin spine, and a pampas grass sliver in the palm. And so we've used it a fair amount with good results. And it turns out it's the shape of the foreign body that makes it echogenic, not the composition. So most foreign bodies are always uniformly fairly echogenic, whether it be wood, glass, plastic, metal. It's often just because they have fairly linear orientation. The thing that allows it to get into the skin, meaning it's long and skinny, is the same thing that allows it to reflect the acoustic beam and makes it echogenic. If it's been there for more than 24 hours, you can start to identify this hypoechoic ring, which is the edema, and eventually could potentially turn into an abscess over time. These are some examples from a radiographics article of a patient with a 37-year-old guy with a wood splinter in the palm of his hand, which was a colt on radiographs. You can see how big this thing is on ultrasound. Here's a different patient, 6-year-old boy, 1 month after stepping on a large splinter. Here's the splinter itself. You can see the ring of decreased echo texture surrounding it, the kind of long-standing edema and reactive change to the splinter. And this is a glass fragment in the foot. You can actually see a portion of it impaling the plantar fascia right here. So we've also mentioned ultrasound a little bit for fractures. Now, there is a small body of literature out there that talks about using ultrasound to evaluate for stress fractures in the foot, and again, using a high-frequency transducer. And I think that this actually has some benefit for those of us sitting in this room, because we may not always be in a position where MRI is available. Obviously, I think MRI is going to have a higher sensitivity and higher specificity, but in a deployed scenario where you may only have plain films and ultrasound, this could certainly come in handy. If you have a negative plain film, an ultrasound interrogation of the metatarsal may show changes before plain film radiography would for a stress fracture. But again, if I'm at David Grant, I still would prefer an MRI as opposed to an ultrasound. But this is an example of loss of that normal cortical line, where you just see the nice focal normal interface with a few shadowing. Here you see interruption and exuberance surrounding that normal cortical line. Doppler shows some increased hyperemia surrounding that healing callus. In this case, it was radiographically present, but you could expect a similar change without the radiographic findings. It's amazing. Sometimes you'll ultrasound a chronic tendonopathy and you'll see pretty extensive echogenicity and shadowing from small calcifications deposited within the tendon, which have either little or no radiographic correlate. And so ultrasound can pick up those changes before you see them on radiographs, similar to like you would in breast imaging as well. So this is a topic that maybe at some point we should kind of condense everything from these 2 days for those of us that are military radiologists, because there will be a time where we're downrange and ultrasound may be our only additional modality as opposed to plain films. And so how could this help us if we're deployed? Well, a lot of things we can see on ultrasound that we're used to looking at on MRI, such as tendons, ligaments, Morton's neuroma, or potentially stress fractures, and certainly a foreign body evaluation, and you've got the ability to guide therapeutic injection. Now, at this point, there's one lecture left. You started the week, or at least the conference, excited about learning about ultrasound. Now you realize all the potentials and the possibilities, and had absolutely no idea what was over your head about to fall on you. But just remember, if you know the anatomy, you'll know what to look for on ultrasound, and that's the benefit and the beauty of being a radiologist is we're anatomists, and hopefully if we do our job well, we'll be able to transfer that knowledge from MRI or CT to ultrasound equally. And so in conclusion, ultrasound is better than MRI or radiographs for certain indications. Just because we can't image something, does that mean we should? If they're not going to treat a radial collateral tear of the DIP of the fourth toe, a medial collateral tear of that ligament, does that mean I should try to look for it? But certainly we have the ability to, and ultrasound may be a more common modality when deployed as opposed to other more advanced techniques.